Hi, my name is Brittany Copeland from the Southeast AIDS Training and Education Center. Dr. Livingston is going to talk about HIV and cardiovascular disease with a focus on lipid management. Dr. Livingston does not have any relevant conflicts of interest, financial or otherwise. The objectives for today for patients living with HIV/AIDS include determining the need for statin therapy considering both the ATP IV guidelines and HIV-associated risk, to recognize critical drug interactions in the management of lipids and blood pressure, and to understand the cardiac risk associated with combined antiretroviral therapy. So we'll go ahead and get to the case. I want to apologize, a little bit of it was cut off.
On treatment, you've really been focused on treating his HIV/AIDS. He's been undetectable on his viral load for the last 6 months. And his CD4 count is 210, and on his baseline genotype, he had some NRTI resistance. His blood pressure is just a touch high on the diastolic today at his visit, and that's him getting amlodipine 5 milligrams daily. His antiretrovirals are boosted darunavir and Truvada, and he's been smoking a pack a day for the last 30 years. And as is often the case with AIDS, a lot of times when people have advanced disease, they may have lost weight. Their lipids might not actually look that bad. And then as you get someone on antiretrovirals, in part because they're gaining back that weight, but also sometimes because of the antiretrovirals, we'll see some increase in the lipid profile. So you see the LDL going from 90 to 125. You see the triglycerides having a much bigger effect, where they are almost doubling, and hopefully you're getting a fasting sample, because that's really affects your triglycerides a lot. And you actually have some increase in the HDL, which is actually a good thing. And we do sometimes talk about non-HDL cholesterol, but I won't talk about that at this moment. So everyone take a minute to think about it. Maybe type in the chat box. What do you think would be the best treatment option? Would you choose, and you could choose more than one of these if you like. Let me see if I can visualize the chat box. Let's see.
Okay, I just went ahead and unmuted everyone.
Okay, yeah. Could somebody want to raise their hand and offer a response?
Pravastatin.
Let me just pull my slide back up here. Is everyone still seeing my screen? Cool. So someone said Pravastatin. Okay, so Pravastatin 20 milligrams. Any reason for that choice in particular?
It'll bring down the LDL and the triglycerides, and I believe it's safer with some of the antiretrovirals, but I don't know as much about that yet.
Okay, that's a pretty good first impression. Anybody else have other thoughts?
I like the atorvastatin and work on diet and lifestyle.
Okay, yeah, we get so focused on medication, we definitely do need to talk about the lifestyle piece. And atorvastatin, there is some interaction there, but we'll talk about that. But it may be a good choice anyway. Anything else? Okay, we'll go over. So we'll look at these different responses. So A and B are both fibrate therapy, and there was a time when we used a lot of fibrate therapy in HIV. A lot of the lipid abnormalities we saw were increased triglycerides, but it turns out that lowering triglycerides with fibrates has a minimal effect on the risk of heart attack and stroke. So we've really moved more and more away from that. There are still a handful of patients with very high triglycerides, 500 or 1,000, and maybe their LDL is not that bad, and we might use them in some patients. Simvastatin is contraindicated because of the ritonavir, so if you wanted to use that, it would have to be with a different set of antiretrovirals. Rosuvastatin you can use, and in fact I frequently do use, but you can't use the 40 milligram dose when you're using ritonavir or cobicistat. So we really maxed out at 10 milligrams there, but it's acting like 20 or 40 milligrams, so it's acting like a high-intensity statin. Rosuvastatin is usually the most expensive one at this point. So usually we'll end up using a atorvastatin instead. Similar story with the atorvastatin. It interacts with ritonavir. The levels get increased, so you can use it, but you try to keep the doses low, like 10 or 20. So that would be a fair thing to do. And a lot of times with the drug interactions, I might start low and then up titrate once I know they're tolerating. One of the advantages to pravastatin, now that dose is pretty low. It doesn't interact with ritonavir. You'd probably like to up titrate it as time goes by. And it does have the lowest incidence of myopathy. So it can be a nice choice, and it's often very cheap. It's on the $4 list. And of course, working on diet and lifestyle. The only caution with H, in this patient, there was a history of NRTI resistance that was partial, which when you're putting the NRTIs with boosted darunavir, you're going to be in good shape. But if you have a compromised NRTI backbone and then you move from a boosted protease inhibitor to an integrase inhibitor, you actually might have increasing viremia in some cases. So in this case, in other cases, you might have an intact NRTI backbone, and that might be a fine thing to do to help their lipids a little bit. It'll improve their LDL, maybe 10 points, improve triglycerides, maybe even 50 points. And the HDL will also go down. So moving on. So one thing we really care a lot about is what is the risk of having a heart attack or a heart attack equivalent or a stroke in the next 10 years. And we used to estimate this with the Framingham scale, which is based on one very large database of patients. If we look at this patient in that scale, they had a 23% risk of a heart attack in the next 10 years. And we consider, 7.5% and above to be significant. And definitely as you get up over 10, 15, 20, you're talking about a high-risk patient in this case. Really, the only higher risk patient than this gentleman would be somebody who already has known coronary artery disease. And now there were some things that weren't taken into account by Framingham, and one of them was ethnicity. And in fact, African-American men, for example, their cardiovascular risk goes up at an earlier age. So for a lot of our patients, this is important to take into account, and we're going to see a higher risk on the new calculator that came out with ATP IV, the most recent guidelines. So this patient in those guidelines has a 26% 10-year risk of coronary artery disease. Now you know that doesn't take into account at all his HIV, which we know is a risk factor for cardiovascular disease. And we'll talk more about that, but I might consider this person to have more like a 30 or maybe even 35% 10-year risk of coronary artery disease, although I can't define it perfectly. This is a high-risk patient. And this is just one place that you can find the risk calculator online, but it's actually really easy if you just put in ACC risk calculator, that's American College of Cardiology, on Google. You won't have any trouble finding this. A lot of you are probably using it already. But this is a good way to determine who's going to be a good candidate for statin therapy. But as I just mentioned, HIV itself is a risk factor for myocardial infarction and coronary artery disease. So there have been multiple very large cohorts with many thousands of patients that have seen roughly a 50% increased risk in myocardial infarction in patients with HIV compared to age-matched controls. And that's controlling for the other risk factors that we know are more common in HIV, things like smoking, which for example is more prevalent in the HIV positive population. And this DAD cohort is one you'll hear talked about a lot. It's a multi-center from the US, Europe, and Australia, many thousands of patients with many years of follow-up. And they found the Framingham score, for example, underestimated the 5-year risk of myocardial infarction. Another interesting study, and in this case, not where you're just following patients, but where you're actually doing a randomized control trial, is they looked at having people just take their antiretrovirals continuously or letting them have breaks when their T cells got to a certain good level, taking them off their antiretrovirals for a number of months, waiting for the T cells to drop and reinitiating if they got low before harm would ensue. But what they found was that there was actually a higher rate of non-AIDS complications in the patients who had breaks from their medicines So certainly we know that interrupting therapy seems to increase immune activation and inflammation and increase your risk of myocardial infarction, which is in some ways an inflammatory disease. And they also saw when they put people back on their antiretrovirals that the rate of myocardial infarction decreased. So this was an unexpected result from this trial, but turns out that uncontrolled HIV viremia is actually bad for your coronaries and is associated with high-risk plaque. So let's move on. So in general, you kind of have a fudge factor. If the calculator tells you there's a 6% 10-year risk of coronary artery disease in a patient and they have HIV, it really might be more like 8 or 9% in terms of their actual risk. And again, we can't quantify it perfectly, but we know we're underestimating with our calculators. And this is just a summary slide from the new guidelines if you don't have this, but this is definitely accessible in a lot of places. In general, we talk about giving people either moderate or high intensity statin therapy. Really the only time we'd be using very low doses might be someone who just has intolerance of higher doses like myopathy. Although it is fair to start low and go up slowly if you prefer with your patient. And then the folks who we really want to push the dose as much as possible are people who we already know they have coronary artery disease, or people that have very, very high LDL over 190, or patients with diabetes and multiple other risk factors that put their risk over 7.5% for 10 years. And with the high intensity statin, we're cutting the risk of heart attack by about a third. So it's a pretty substantial. It's not perfect, but it's a nice piece of the puzzle for keeping people safer. So you can imagine if someone's risk for 10 years for a heart attack is 3%, we're only really going to push it to 2%. So we may not want to treat that person. But if they're coming in at 20%, we might be able to push it down to say 13% and really have a decent chance of benefiting them. And I did put, again, with atorvastatin and rosuvastatin, you would be using lower doses if there's ritonavir or cobicistat in the mix. Another thing would be, again, not just did someone have an MI in the past for the highest risk people, did they have an ischemic stroke in the past? Have they had a TIA? Or do they have a history of peripheral vascular disease? They would also merit high intensity statin. And additional updates from the most recent guidelines. We used to talk so much about trying to get people to goal with their LDL. And the emphasis now is much more on getting people on the highest dose of statin that they can tolerate, since that's the main cholesterol lowering agent that has really shown a decrease in cardiovascular events. Other medicines change lipids, but really don't seem to affect outcomes very much. You're supposed to, get those baseline lipids, put the person on the statin if they need it, and then get one more set of lipids after that to see, did they have the expected decline in LDL? Because if they don't have any decline in LDL, they're not taking the statin, or they decided to go on an all cream diet or something like that. But so you don't really have to check lipids anywhere near as much. I think we're in the habit sometimes of checking every year in primary care and in HIV, and it's probably excessive, especially once you already have someone on a maximum dose of a therapy. And they really didn't emphasize any other lipid-lowering therapies because there's been a lot of negative studies for fibrates and niacin, and ezetimibe's been questioned, although there's a recent study that it may be helpful in some cases. What else should we know? In terms of the antiretrovirals we choose, turns out that Truvada is better for lipids than Epsicom. So we see maybe about 15 points higher in terms of LDL in folks who are on Epsicom, and if you switch them to Truvada, it goes down. That's not to say that there's a lot of patients where we are still avoiding Truvada, but it's kind of one more reason to have Truvada be your default. We're seeing pretty favorable lipid profiles with most of the integrase inhibitor-based regimens that have come on the market recently. Also, Complera has been pretty good for lipids. Also, again, you've just got to be aware with cobicistat. We're going to see more and more cobicistat that the drug interactions are very similar to ritonavir with a few exceptions. So having to be careful with statins there. And also you should know that some of the NNRTIs affect the liver enzymes and actually can lower levels of multiple statin drugs. So you're always having to look that up. You should be pretty familiar. Patients, a lot of patients are wary of statins. So just to give you a sense of the real risks here, the main thing we see is myopathy. It occurs in 2 to 11% in different trials based on different doses and different agents. And most people will feel bad. It's going to take usually weeks to months, and they'll know that they have myopathy. You don't have to screen CPK. You may, if you're they have symptoms that could be myopathy, I would check a CPK to see if it's that. But if they get those symptoms, you can change them to a different statin. Pravastatin is the one that causes the least muscle issue. But it's not going to be, it's very, very rare that this reaches the level of rhabdomyolysis. And if you kind of warn people about muscle aches, that's something you're just not going to see very much at all. So in terms of muscle, you definitely will see side effects, but in general, switching them or maybe even taking them off statins will take care of it. It's not going to cause lasting harm. And in 90% of folks, they're not going to have any muscle issues. And then there's been a lot of talk about, causing diabetes by putting people on statins, probably having a modest effect on a modest hyperglycemic effect in folks who are probably at risk to begin with. So we're saying if you treat, 200, 300 patients with statins, you may have one patient who increases their A1C to the level of having diabetes, which is important. I mean, if you're treating very low risk patients, you may be as likely to cause them diabetes or a muscle problem as you are to prevent a heart attack. So that's part of the reason of not wanting to treat people who have very low risk. But it's definitely not common. And if they do get diabetes, you're usually keeping them on the statin because it's become even more important. LFTs we used to monitor, that's no longer, the new guidelines say not to bother monitoring that. In the HIV world, we're usually getting those anyway. And cognitive deficits has gotten a lot of press. It might be true in a few rare cases that a person has had some memory issues or other cognitive issues while on a statin that went away with stopping it, but it really hasn't panned out as anything that's common at all based on some larger studies lately. Triglycerides comes up a lot. I'm not going to be exhaustive here, but I just want you to have some basics. In general, they're much more diet responsive than LDL, so you can definitely work on diet for a long time with these folks. They're not a great predictor of cardiac disease. The one time to be worried is when you see triglycerides like near or above 1,000 because there's a risk of pancreatitis. Also know that if you have a patient with diabetes that's not controlled, that's actually playing into their high triglycerides. As you control their sugars, you'll usually see improvement in the triglycerides as well. Also, hypothyroid states can cause high triglycerides, as well as some of the hormones that we give people, both male and female hormones. Again, the fibrates are rarely necessary. And if you use both fibrate and statin, now you get much higher rates of myopathy. In fact, you're not supposed to use gemfibrozil with statins at all. So keep that in mind. And then fish oil is nice and benign, but there's been a lot of large studies that really haven't seen, much of a benefit. Nothing like the benefits we see with statins. So I'm not a big fan of fish oil. They do improve your lipid profile, and some patients may prefer them because they have an alternative approach to health, and that's fine. There's a recent trial that came out this year with this question of ezetimibe as another medicine that can lower LDL. They did a large randomized trial of taking people who had already had heart attacks right after their heart attack or unstable angina and putting them either on just simvastatin or simvastatin and ezetimibe or Zetia. And they actually got LDL levels that were very, very low. One group, just the statin group, their LDL was 70. And with ezetimibe, it got down to 55. And you say, you're really going to see much benefit there? And they actually did see an additional 2% reduction. That's 2% absolute risk reduction. So if you treat 50 patients, you're going to prevent 1 heart attack, stroke, or cardiac death, and it's a very safe medicine. So this also supports the theory that for a long time we talked about LDL goals, but even somebody with an LDL of 80, if they're a very high-risk patient, can benefit from having an LDL of 50. I'm not using very much Zetia at this point, but if I'm going to start using it in my folks who have known coronary artery disease and who I might be able to get their lipids a little bit lower by adding that on, and it's a once daily and well tolerated. But it's a small change, so and this is a very high risk population. It may not have a big effect in folks who are lower risk, so I'm not going to use it super widely. Yes, I would note on abacavir, this question comes up a lot if the patients are poking around online. And a lot of times we'll warn people about this question of cardiovascular risk with abacavir. So there's a lot of conflicting data on this question. When they've looked at a meta-analysis of all of the randomized control trials, they don't see any increased risk of myocardial infarction with abacavir. So that's pretty convincing. It's a lot of patients. The only thing is, in randomized control trials, they usually select healthier patients, often younger patients who probably weren't going to have a heart attack. And there is a question of, could it be risky in patients who have more risk factors for heart attacks? So when they've looked at large cohorts in the US and Europe, they have seen an association with abacavir use in MI. Now that could be because those are patients where they're avoiding tenofovir because of high blood pressure or kidney issues, and maybe it's just the fact that they're using abacavir in higher risk patients. So we're seeing some conflicting results there. For me, I try to avoid abacavir in my high risk patients, people who have had heart attacks, strokes, or this very high risk, like the patient in the case where it's a 25% risk of heart attack in the next 10 years. If I have to use it to kind of make things simple or based on the resistance profile, that kind of thing, I will. But if I can avoid it, I do. And then I think we've already talked about these, so I'm not gonna. We're getting towards the end there. I want to get to questions. And then just be aware, hypertension is not very different at all in HIV and non-HIV. The biggest thing is just that calcium channel blockers have an interaction with ritonavir and cobicistat. You can still use them, but you want to start at low doses, and you'll probably see a little bit more in the way of side effects, for instance, edema with amlodipine. We recently saw a rare case of someone who actually got heart block from amlodipine plus ritonavir, which is pretty unusual and you sort of unexpected, but just something to be aware of. And that's everything. So I want to move to questions.